I was supposed to deliver this talk in the evening, but since we already analyzed we analyzed a piece of data in one way. Now I'm going to analyze the same set of data in a different way, because I'm not going to talk about conduction system more in this talk, but I'll be talking about the low risk TAVR, when and why. So again, the same first patient, I'll just skip that. The partner trial, we all know that in the partner trial, extreme risk patient, the average age of the patient was around 84 years. And of course, if you see 84 years, having a 33 months of improvement of life in patients where nothing was working out with a good quality of life, that's excellent. Uh, Again, what we analyzed here was death from any case, any cause, hospitalization, no stroke, and all those things. But mind it, here it was a prohibitive risk patient. We moved down to a 2-year follow-up, and with a good result, we saw that partner both 1A and 1B had a good result in comparison to surgery. Either it was equivalent to surgery, or it was better than surgery. We then saw that, okay, another platform of valve, that is a self-expandable valve, was doing as good as a balloon expandable valve, and this added confidence to the therapy. We also saw that the effective orifice area and the gradient were lower with the TAVI valve than in comparison with the surgical valves. And the 3-year follow-up was extremely encouraging, and that led to the intermediate trials. In the intermediate trials, we showed that the TAVI valve was as good as the surgical valve. But again, what was the age group of the patient? The age group of the patient was again 82 in these patients. We are talking about intermediate risk, where we talk about the STS score being as 4 to 6%. And still the age group is 83. Now, if you look at a lot of patients in this intermediate group and the high risk group, they are 83 years. Now, if I have to tell whether the valve will outlive the patient or the natural history of the patient is going to outlive the patient, of course, we all know that natural history is going to outlive the valve. That is, the patient is going to die of the natural history after the valve implantation rather than degeneration of the valve. So it is more natural to have 25% mortality or a 12% mortality or a 6% mortality in these patients. But we are talking about intermediate risk, and we want to have a mortality less than at least 6% in these patients. And that is what the partner 2 trial and the SORTA-V trial showed to us. Guidelines changed, as I told in the previous presentation. We moved down to low risk trial, and when we moved down to low risk trial, we knew that we cannot have a large number of patients in this trial. So what we did is we used a Bayesian analysis, wherein we are able to predict the same outcome with a low number of patients at 2 years, 5 years, very confidently in comparison to surgery. And in the low risk trial, we could see that TAVR was better than surgery. Now, we should also look at what is the difference between the intermediate and the low risk trial in regard to a self-expandable and a balloon expandable valve. And in both intermediate and the low risk trial, the self-expandable valve, if you see, did better. In a sense, if I have to tell that at the end of 2 years, in an intermediate risk class, in a balloon expandable valve, the SAVR patient had started doing better than the TAVR patient. Here, in both the class, it was TAVR valve. But if you go into a low risk patient, you will see that both balloon expandable valve and the self-expandable valve had done equally good in this subset of patients. Now, if you see, we changed the guidelines completely. And now a TAVR is a class 1 for 80 years, more than 80 years. For 65 to 80, you may discuss with the patient and all those. So if I have to tell what was the difference in the low risk patient, why a balloon expandable valve came up so well in comparison to a self expandable valve, then you see in a low risk trial, in a balloon expandable, that is the partner trial, it was all S3 that was implanted. But if you go towards the low risk evolute trial, then you'll find that 1/3 of the patient were still the second generation valve. A quarter of these patients only received the present generation valves, and that could be one of the one of the bias point in this trial as well. What you see in this trial, the rate of permanent pacemaker implantation, and you see in partner trial, that is with the self-expandable valve, you have no difference with the surgical valve in the rate of pacemaker implantation. But if you see with the low evolute low risk trial, okay, there is a huge difference. Now, that we all know that a self-expandable valve, we slowly learned how to put a self-expandable valve at a higher position, at a 3 mm position, and we got the pacemaker rate down. And this is what this slide shows. This slide clearly shows that if this is the center of Hemangada, where the pacemaker rate was just 1.9%. This is somewhere like Michael Radian, where the pacemaker rate was 4.9%. This is another center in US. The operator volume does matter, and the operator understanding does matter with regard to the pacemaker. And now we have come down over a period of time after using the cuspal overlap technique. What we have come down in 2020 after the introduction of cuspal overlap technique, even with the self-expandable valve, the pacemaker rate is just 8.5%, extremely low. I do understand that with a balloon expandable, it is 6%, but still we can see that there is no difference. The low risk trial in the case of balloon expandable can clearly be seen that the gradient went slightly higher than the surgical arm, as well as the aortic valve area went slightly higher. Whereas in the evolute arm, the TAVI valve did better than the surgical valve. If you see this trial done by Rebecca, you will find this is the all-comer trial. She was the main core valve analysis person in both the trials. So she found that in SAPIEN, if you implant a SAPIEN, the effective orifice area is going to be 1.66%, 1.66 centimeter square with a mean gradient of 11. And if you implant a evolute R, it is going to be something like 2.1 plus minus 7 if you go to the gradient. Rahimtullah clearly showed that there is something called as patient prosthesis mismatch, but his definition was quite different to the present day definition. And the present day definition comes from this trial. And this trial clearly shows that if you have a effective orifice area, indexed effective orifice area less than 0.65%, your gradient is much higher than if you have at 0.85. And that led to this definition of ppm, wherein you have no ppm if the indexed effective orifice area is more than 0.85. You have severe ppm if it is less than 0.65. In between, it is moderate. And this has been clearly shown that as the effective orifice area decreases, the gradient starts increasing, and with the increase of increasing patient prosthesis mismatch, the mortality also increases. Now, this beautiful trial clearly showed that in 60,000 patients, low risk, because it's 65 years old patients, surgical patients, if these patients have any degree of patient prosthesis mismatch, the mortality increases. And this is quite evident. This trial also showed that if you have patient prosthesis mismatch, your structural valve deterioration is going to be faster. Now, if you see the survival and the structural valve deterioration, then the only one factor matters, that is the patient prosthesis mismatch, where if a patient has a patient prosthesis mismatch, both the survival as well as the structural valve deterioration is higher. Now you can clearly see the patient prosthesis mismatch is almost increasing by two times in the case of surgical versus the evolute platform, whereas the patient prostatic mismatch is higher in the patron trial, that is in the balloon expandable trial. And this, we all know the reason for this particular thing. Now, let me analyze this beautiful data. You have a younger patient. At a normal rate, even in a younger patient, if he doesn't do anything, that is, his aortic flow doesn't increase, the gradient is going to remain the same. And so the valve deterioration is not going to be high. And this is the case if the patient age is more than 80 years. But if you have a 65 years old patient, he's going to run around, his aortic flow is going to increase. And when his aortic flow is going to increase, his gradient is going to increase and mortality is going to increase. So if you want to give a valve to a younger patient, please keep in mind the patient prostatic mismatch subset of these patients. Even we can see that the 6-minute walk test, at the end of 1 month, the TAVI valve had a better 6-minute walk test in comparison to the surgical valve. It is clearly seen. That may be because of the surgery. The patient has undergone surgery. He doesn't want to move around. But at 1 year, you will think that, okay, that should catch up if there is no difference. But we don't see that at 1 year. We don't see that at 2 years. We don't see even that at 2 years. So what has happened? Basically, TAVI has done better than the surgical valve in these regards. So do I mean to say that all low-risk patients should undergo TAVI? No, it is not that way. In those patients who selected group of patients who underwent that trial, those patients subset TAVI is better than surgery. But there were a whole subset of people who were excluded from the trials. The bicuspid aortic valve, patient with significant coronary artery disease, patient with unfavorable anatomy, associated other procedures, or patient who is suitable for mechanical valve, they all were excluded. So you cannot just say that I'm going to put a TAVI valve in this subset of people, because this subset of people have never been studied. So let me show some data. Bicuspid aortic valve, younger patients have a higher chance of bicuspid aortic valve. Earlier generation valve did worse than the present generation valve in regard to bicuspid aortic valve. But let me show you this this low risk bicuspid aortic valve trial, and you'll see that these patients did equivalent to surgery, and in these patients the result was similar to the tricuspid aortic valve. In fact, the paravalvular leak surprisingly was lower than the tricuspid aortic valve in this trial, and that surprised me quite a lot. What about people less than 65 years? If you see both the low risk trial, the age of the patient has still been, the mean age of the patient has been around 73, 74 years. We have not still looked into 65 years or lower than 65 years. In the partner trial, lower than 65, only 7% of the patient were less than 65 years. In the Evolute trial, 65 years, 6%, similar. Less than 60 years, 1.3%. But please don't go by that. These were the patients who were given TAVI valve due to certain conditions of the patient, not because that the patient had to get a TAVI valve. Now, if you see, what about the anatomy? Too large anatomy, you may not be able to put a TAVI valve. Now we have extra large valves, so we can do a TAVI in these patients. Too small anatomy, like 15, 16, are you going to put a TAVI valve? No, you are going to have a large amount of patient prostatic mismatch. It is better to give to the surgeon. The surgeons have learned over a period of time that you need to enlarge the valve. What may be the reason that in intermediate risk trial, at 3 years, both the surgical risk and the surgery patient as well as the TAVI patient, the surgery patient started doing better, because we made the surgeon feel that you need to learn how to enlarge the valve, and they learned that, and they started doing root enlargement, and that result showed in the intermediate trials. So too small anatomy, you can still give it to the surgeon and say that, okay, you can do a root enlargement and that will be better. Excessive alveolar calcification has been ruled out from all the low risk trials. So please don't consider that those subset of patient in TAVI group, because this subset of patients are going to have a higher pacemaker rate, higher paravalvular leak rate, and of course, the mortality is going to be different in these patients. Now, let's see the two trials. It was told that it is all-comer trials, but see the amount of screen failure in both the cases. 1/3 of the patient had screen failure in partner 3 trial, and around 15% of the patient had a screen failure in the case of Evolut trial. It clearly shows that it was not an all-comer trial, but it was these patients were put to a particular committee, and the committee decided whether to take the patient or not. So it was a biased trial in comparison to surgery. It clearly shows that. What about syntax and coronary artery disease? If you see partner trial, clearly excluded syntax more than 32. Evolut, it was said that more than 22 should be excluded. What was the reality? In reality, in syntax score more than 7, hardly any patient had syntax score more than 7 in Evolut trial. That means we had extremely excluded all kind of coronary artery disease. We have not tested in coronary artery disease. So we should not think about giving these valves in a low risk patient with the coronary artery disease. The surgeons will say that, okay, our valve is going to last 10 years. But if you see what is the number at risk, you see 40 patient you started with, at the end of 10 years, you are analyzing only 1 patient, and you tell that our valve lasts for 10 years or 15 years. Even if you see at 15 years, what is the number at risk? Number at risk is extremely low. You started with 1,000 patients, known patient with a number at risk, 11 patients. These trials are extremely flawed trials to tell that the surgical valve is going to last 15 or 25 years, because you need to consider all the patients that were enrolled in that trial. You cannot say that at that point of time, only this much patient came, and I'm going to analyze only these data. We also know that certain surgical valves fail over a period of time, and trifecta is one which has shown degeneration even in 1 year time. So this kind of valves should be taken out of the trials. We have seen that the durability of the TAVR valve has lasted quite a bit, and 5 years data of all these trials are available, and these 5 years data have done better than surgery or equivalent to surgery. The NOSEN trial is the a holy grail of durability trial in all the TAVI valves, and it has shown up to even now 10 years data is available. I'm just showing you up to 8 years data, and all cause mortalities, SVD, everything was lower in the TAVR valve. But finally, when the NOSEN trial 5-year was analyzed, it was seen that the pacemaker rate was higher in the TAVI group, and atrial fibrillation was higher in the surgical group. Surgical group atrial fibrillation has not changed over a period of time. NOSEN trial started in 2011. By 2016, we saw that, okay, the pacemaker rate is higher, and we learned that how to bring that down. We have already learned how to get our pacemaker rate down, but the surgical atrial fibrillation rate has not changed over a period of time. PVL is the Achilles tendon of TAVR, but then again, with the advent of newer valves, PVL rate has come down extremely low. If you are going to give a TAVR valve to a patient, make sure that the PVL is less than mild, that is trace to mild, not more than mild, because you are going to increase the mortality in that patient over a period of time. As I told, over a period of time, the PVL rate has come down extremely low in TAVR group in comparison to the SAVR group. So to conclude, if you are going to give a TAVR to a low-risk patient, consider the patient population that you are treating. You are treating a bicuspid, you are treating a heavily calcified. Slightly, you need to be cautious about it, because no trials has shown any kind of outcome in this. And we need to give a better trial to say that, okay, this valve population can be treated with a TAVR valve. Consider the anatomy, what you are dealing with. Alveotic calcification and bicuspid aortic valve. Please think about SAVR in this low-risk patient. Consider patient prosthesis mismatch. If you have a very small annulus, please give it to the surgeon. They are going to do a better job by root enlargement. Of course, they also need to learn how to do a root enlargement, and then only they are going to improve their result as well. Consider the chance of pacemaker. As much as possible, try to come out of the lab without any kind of pacemaker in this subset of patient. Consider the chance of paravalvular leak. When you come out of the lab, you should have a patient with less than mild paravalvular leak on the table. And also consider like if this valve is going to fail, what am I going to do with the patient? Now, if you see the guidelines, it clearly says that the patient should have a minimum life expectancy of 1 year for TAVR. And if the patient has a life expectancy of more than 20 years, then you will have to sit down and discuss with the patient, because the TAVR valve is ultimately failed because it is a bioprosthetic valve. In the previous talk, it was told that the difference between bovine pericardium and the porcine pericardium. Now, if you look at the bovine and porcine pericardium, the halt, that is the thickness, increase in thickness, is more in bovine than in porcine pericardium. Now, if you look, most of the surgical valves are bovine pericardium. So the halt is going to be higher. The rate of thrombosis is going to be higher. The rate of valve degeneration is going to be higher in these patients. Now, if you ask, why haven't the companies changed those valves to a porcine valve then after all these years? The reason is, if they're going to change the material, then they will have to go through all those FDA trials again. And doing that is going to be a huge task. Probably we need to see and find a sweet point where we need to decide that TAVR or SAVR is going to be a better solution for this patient. Thank you so much.